Recording.
Good afternoon. Thank you for joining us. Today we are going to be discussing provider credentialing, and we are going to be talking more in detail about reducing fraud and managing medical costs and focusing on quality outcomes. But before I do that, let me introduce myself. I am Michelle Berry. I am with Availity here in Jacksonville, Florida, and we are a trading partner vendor clearinghouse throughout the country, and we are working directly with our industry collectively as WEDI, and I am co-chairing the Provider Information Subworkgroup at WEDI. So again, thank you for joining us. Appreciate your time today, and as we get into more of a discussion about who we are and what we're doing and why we're focusing on concentrating on what is credentialing and who's a part of credentialing. So we're going to go into more of that aspect here in just a few minutes, but a couple of housekeeping tips. This is our WEDI disclaimer. In addition, we do have some topics that are important for our discussion today. First, we're talking about credentialing alphabet soup. What are all these acronyms? What does it mean when you say CVO versus NCQA versus PSV? What do those acronyms mean? And how do we use those acronyms? Second, we're going to talk about what is credentialing, meaning from a practitioner versus an MD, DO, physician, mid-level practitioner to a therapist or an actual facility that can include an FQHC, a federally qualified rural health clinic, or even getting into the discussion about an acute care or even behavioral health facilities. So again, we're going to be talking about what is credentialing and who is a part of that credentialing and why is it needed in the industry, in our healthcare industry. Then we're going to focus more on when and how often providers need to be credentialed and or re-credentialed. And you'll hear some terms called credentialing, initial credentialing versus re-cred, which again is an individual practitioner or facility that has already gone through the initial credentialing or credentialing. And then talk about some interesting facts. And of course, this information goes very far deep into how long credentialing has been around, but really focusing on us as an industry doing studies from 2014 and across the United States as it relates to providers and credentialing. A couple of items of housekeeping tips in addition to what we talked about. The alphabet soup that you may hear in the industry really focuses around these terms. NCQA, which is the National Committee for Quality Assurance, they're really focused on creating those standards, those guidelines, and actually taking measurements, performance measurements, and moving that into a realistic audit process. So we'll talk more about that later on as we get into the second series of provider credentialing. Again, this is first of many series and wanted to start off with the acronyms. CVO, Credentialing Verification Organization. This is an entity that is certified through either NCQA or URAC, specifically around those standards. They're being monitored, tracked, and trended, and they are certified to render specific services in the credentialing environment. The PSV is your primary source verification. This is a process that your CVO that is credentialed through NCQA or URAC utilizes to authenticate data for a particular practitioner, physician, brick and mortar facility. Also, some other acronyms that I think are important as we go through this first series and our continuing series of credentialing. CMS, Centers for Medicare and Medicaid Services, specifically around the Department of Health and Human Services, the federal entity that oversees the Medicare and Medicaid programs. DO, Doctor of Osteopathy, these are individual practitioners who render services to different individuals, ranging from anything from an ENT, ear, nose, and throat, to actually physical therapy. Then you've got your MD, your medical doctor, which is primarily prominent in our industry. So you do have some specialists that go with MDs, specifically around cardiologists, radiologists, oncologists, individuals who practice in a particular specialty. And then last but not least, this is an interesting term, and you'll see it utilized in this particular series, but the international medical graduates. These are individuals who may have obtained a degree in a foreign country or another country and have come to the United States and become a U.S. citizen. And again, there are certain levels after an IMG is received. There are certain levels that that particular practitioner would have to go through in order to practice medicine in the U.S. and governing territories as well. In addition, talking about credentialing, I know in the industry there are different types of terms and different types of level of credentialing that individuals may have to go through, again, depending on that particular practitioner or that facility, that organization. So keep in mind, a provider, when we use that term in credentialing or throughout the healthcare industries, we're talking about an individual or a brick and mortar. We do have atypical providers who do have to go through a credentialing process, and we'll talk about atypical providers in Series 3, and we'll really focus and hone in on those particular individuals. And let me give you an example of what an atypical provider might be in our healthcare industry. An individual who is contracted with a state Medicaid construction firm who builds wheelchair ramps for Medicaid beneficiaries. And again, that particular entity, that contractor, that construction organization company would contract with the state Medicaid to build those wheelchair ramps for those Medicaid beneficiaries. So those individuals have to go through a credentialing process, but it is very different than our traditional physicians, MDs, DOs, practitioners versus facilities. So again, when we talk about credentialing for this particular purposes, we are talking about either the two-legged, belly button, and or brick and mortar. Credentialing is a process, and it is a very detailed process. Credentialing typically takes place when an individual practitioner and or facility has been recognized as someone that a health plan or a payer would like to bring in their provider network. And when an individual or a brick and mortar, an actual facility decides that they would like to credential with a particular health plan or payer, there is that collaboration, that discussion, and that normal process of officially starting that contract opportunity. So again, understanding that credentialing is a process. It's not just an actual application and you're done. It's more of a collaborative type of process. And again, there is paperwork. There is a whole regiment process that goes through from a health plan payer to a particular provider. But some of the things that I think are very key when we talk about provider credentialing is really focusing on those required elements in the whole primary source verification. And service locations, for instance, if a brick and mortar operates in 5 different locations, each individual distinct location needs to be physically credentialed for that service location. So again, it's not just one application for that particular brick and mortar at that service location. It's going to be one for each of those locations. In addition, the primary source verification also looks at the practice history from an MD, from a physical therapist, a mid-level practitioner perspective. What does that whole history for that individual, what does that look like? And then also, really important, I know references, as we fill out our own individual applications and resumes and we're applying for jobs, people do ask for references. Well, the same thing goes for credentialing. References are a key component of that primary source verification process. And references help delineate that particular individual or that particular brick and mortar. So again, having updated references and updating that credentialing verification organization, the CVO, with that right information so that the primary source verification process can continue. Having that open line of communication is the way I refer to it. In addition, there's also other data elements and qualifiers that are important in the credentialing process. And for reasons, as you probably already know, hospital affiliations are a very key component. Also, if there's a change of ownership, otherwise known in the industry as a chow, and we're going to be discussing what that is further on in our series of credentialing. But just so you know, some of the other data elements and qualifiers that are needed from a credentialing perspective. In addition, we do have other opportunities and we do have other data elements that are necessary and required when an individual practitioner, a doctor, physical therapist, mid-level practitioner comes in and says they want to be a part of a health plan or payers network. There's disclosures that are specific to that individual and that particular state. Some states do have requirements from a disclosure perspective that are needed in the credentialing process. So when the primary source verification is done, that particular individual and all those disclosures will be reviewed and compared to data that is shared in other reports like Death Master. Also, there is what we call an exclusion list, and those exclusion lists are published by the federal government, OIG, the Office of Inspector General, on a regular basis. So those kind of qualifiers and data elements and other components of the application and process are very key. Some of the other things I think we need to be aware of is reviewing of each of the practitioners. We talk about practitioners going through a certain level of residency training. They go through certain elements and components of detailed training, specifically around those individuals who were specializing in a particular area of medicine, radiology, oncology, dental. There's also vision, ophthalmology. Also from a behavioral health, we have psych and substance. We also have those individuals that are even further defined in a particular subspecialty. And we're going to get into all of that information at a totally different session, but wanted to bring it up here because it's important understanding when a practitioner specifically goes through the credentialing process. Training, education, residency, and license are a critical aspect of this whole entire process. License and certifications for a brick and mortar are extremely important. So again, from a review perspective, this information drives the successful outcome of that credential application so that the health plan and the payer are very fully aware of how this provider is engaged in the industry. A couple of other points I think that are important when we talk about the who in credentialing, it could range from anyone in the industry. As I shared earlier, we have atypical providers. I use the construction company as an example who contracts directly with state Medicaid to build those wheelchair ramps. We also have other atypical providers, and again, that is going to be another session. but really focusing on atypicals, physicians, and brick and mortars or facilities. Those are the three who in credentialing that go through an actual process. And again, those processes range depending on the level of taxonomy, complexity, specialty of that particular provider. So some of these individuals that come in and complete a credentialing application, whether it's directly through a health plan, a vendor, or it is through a payer's website or portal, there's also more information that is important for that particular individual. Understanding the level of service that they're going to be providing particular members, beneficiaries, subscribers, dependents for reimbursement from that particular health plan and or payer. CMS, for instance, contracts directly with particular entities or individuals. There are some skilled nursing facilities that are in the marketplace that CMS contracts directly with to render services to Medicare beneficiaries. So again, from a Medicare perspective, that's one example. Individuals participating in this initiative, we as an industry need to really understand more about that particular practitioner and or facility. Prior to an individual physician rendering medical services, and I say this because it's very important key, that individual must go through the process of credentialing with that health plan, with that particular payer. Keep in mind that individual specifically rendering those services have to have all of their credentials vetted and then have a contractual opportunity with that health plan and payer to render those services for those beneficiaries, subscribers, dependents, patients. And again, depending on how this individual is rendering services under what program, whether it's Medicare Advantage, whether it's traditional Medicare, whether it is commercial line of business for a particular health plan, and or if it's from an MCO, a managed care organization. So again, each individual will have to be credentialed for that particular line of business. And it's very important that that process is completed prior to any services being rendered, because again, the provider is looking for ultimately the reimbursement for the quality of care that they are providing. So with that process, again, the training, the education, the experience, competencies, all of that information is verified for those particular individuals. Just like it would be for a facility, making sure that the facility has passed all regulatory requirements and it's not just a four-wall type of brick and mortar. It literally has departments or services that they render for individuals. Again, we talked about a CVO, Credentialing Verification Organization, or otherwise known as Credential Verification Organization, health plan, insurance company, and or CMS. We also talked about payers. Our industry, as we all know, we do have those terms that are used interchangeably, and better understanding that there are differences between the entities. Also, some of the other important key items when we talk about the who in credentialing is we want to make sure that we understand collectively this is helping to reduce provider latency. This is helping to reduce any fraud, waste, and abuse. This is helping to alleviate any unexpected, foreseen circumstances, so that not only is the patient, subscriber, and beneficiary comfortable that knowing your provider or their provider is considered credentialed, certified, authenticated to render services on behalf of that particular health plan that they've contracted with or payer, it allows for the level of care, quality of care to continue. So not only are we increasing awareness, but we're also bringing satisfaction to the healthcare industry by maintaining who is able to be credentialed, who is involved in that process. Now we're going to talk about how and when providers, meaning practitioners and facilities, we're not going to be referring to atypical providers in this particular scenario, but when providers need to credential and or recredential. Credentialing is important, again, as I stated earlier, prior to contracting with a particular health plan and or payer. It's important because you want to start that authentication. We want to know who this provider is coming into the marketplace and providing services. NCQA, if a health plan is certified through NCQA and or URAC, the health plan is also being certified based on how they credential and bring providers into that network. How often are they recredentialing a particular ambulatory surgical center over an acute care facility, and or a mid-level practitioner versus an MD that specializes in cardiology? So again, all of that plays a big factor and role in who, how, and when, and how often individuals versus facilities go through the CRED and recred process. Typically, on an initial CRED process, it is the initial credentialing process that leads to a recred. Recreds can take place every year, depending on the level of practitioner and or facility and the level of services they provide. Again, I mentioned change of ownership. When a facility, skilled nursing facility, is acquired or bought by another skilled nursing facility, that change of ownership starts that recredentialing process. So the facility will have to start the recredentialing process once that change of ownership has been completed. NCQA also helps with accrediting or certifying health plans and payers, especially when we talk about having credentialing and recred occur depending on if the provider is coming in participating in a managed care organization, an MCO, which is the state Medicaid program, versus traditional Medicare versus Medicare Advantage organization through an independent health plan and or payer. So keeping all of that active, NCQA helps the health plans maintain their certification by conducting audits on their their initial credentialing applications and their recred applications. And health plans typically go through an NCQA certification and recertification every 3 years as well. So again, this goes hand in hand. Some health plans have certain dates for the group of their providers to go through a recred process, and or CMS may have an actual time frame for their individual physicians and brick and mortars facilities to go through the recred process. Keeping in mind, recredentialing doesn't end. The industry as we know it today is becoming more engaged with the recredentialing process once the initial CRED has been established and the recred date has been determined. And again, we're talking clean initial credentialing here in my example that leads to a recred of a particular practitioner and facility. It's important to understand that the health plans also have to keep updated with provider information specific to those applications that they have completed on behalf of the providers that are in their network. So again, recredentialing is a continual process, and it continues until an individual is no longer considering practicing in a particular health plan, or even if a physician retires. They notify their health plans and their payers that they are retiring. So again, there is a lot involved in the process that we're talking about when we talk about recred. Recred, again, never stops for these entities, health plans, as well as payers. Some other things that are important when we talk about recredentialing. focusing on the actual entity and individual as you go through the process is important because you want to make sure that you're re-credentialing those particular individuals every 3 years, but pulling them in around 120 days prior to the re-credentialing date so that you can start the re-credentialing process. And again, you don't want to have a situation where you're waiting till the last month to send out a notification notifying a particular provider and or a provider notifying a health plan or payer that they are ready to recred and it's 30 days out of their recred date. Because the recredentialing process is just as time consuming and focused on disclosures and any additional attachments that are related to this particular individual or facility. So think about it this way. You know, there may be a disclosure that a particular physician may be in a contiguous county where they're on the borderline and servicing multiple members in 2 different states. So the regulatory requirements for that particular individual to maintain their re-credentialing is going to be a little bit different because, again, they're focused on continuing their practice between those 2 particular states and or particular counties within those 2 states. So again, re-credentialing does include a lot of detailed leveled work, but initially it's everything that they originally credentialed. So again, the provider is really filling in those spaces in the recred process that have changed and really focusing in on the disclosures specific to their individual practice or their individual facility. A couple of other things that are really important is the recred process or cycle is very quality focused, just like the initial cred process. So there is no difference in the level of information or the quality of verification of data that is provided. So again, understanding respectfully that there is a process that needs to take place when an individual does go through initial cred versus recred. A couple of interesting facts and figures, and again, as you can see here, this is data from back 2014 when we started looking at really collecting credentialing data and credentialing providers across the U.S. and the specific U.S. territories as well. On average, the age of a particular practitioner, physician, is around between 40 and 49. And again, this is back from 2014 of individual physicians. Number of MDs compared to DOs, as you can see, is a big difference. MDs 91.8% versus DO 8%. And I know this information is back from 2014, but the data is still continuously proving to be higher level number of MDs versus DOs in our country. Because again, you've got those individual medical doctors who are focusing on specific individual types of specialties, taxonomies. Again, like I was referring to earlier, we were talking really about the oncology, dental, vision, ophthalmology, going even into the behavioral health side where we talked about inpatient services versus outpatient services. So again, this is solely focused on the physician types in our country. And then we talked about gender. There was a study done about those individuals who are credentialing and continue to credential. Majority of those individuals are male in the industry as we know it today. Understanding that MDs are becoming more specialized, DOs are also becoming more focused in the areas of bodies focused on the levels of practitioner side of the body system. So again, we're focused on that. We're focused on really driving to stellar level quality individuals coming into the healthcare marketplace, delivering healthcare services and rendering services to those particular individuals who need that level of care. Credentialing those individuals at that level does take more time, as I shared, but having those individuals in the health plan and payer networks faster, quicker, better, so that the health plans can get members directed to those individuals that have been credentialed, re-credentialed, that are in their network, and focusing the well-being and the level of care is what is helping drive the certification, the credentialing, and the re-credentialing process. Some of the other important elements when you look at the geographic location here is really dividing the country up. And again, focusing on what we consider in the industry as based on the studies that we've done, is there are pockets of the U.S. where we consider certain states one particular location. Like, for instance, Florida is considered South Atlantic compared to Mississippi, which is considered the East South Central. And then, of course, Texas and Oklahoma is considered West South Central. And again, when you look at how we look at the data that is coming in on the level of physicians and again, practitioners, level practitioners of those individuals and where they're focusing, and each compartment of the United States has their own detailed level specificity of these physicians. So again, I use the South Atlantic as an example. You have all of these states combined together. The data you can retrieve is based on the South Atlantic data. Again, as you look at information and you look at how health plans participate and payers participate with the providers, that all communication discussion starts with provider relations, the network contracting teams at the health plans and payers, and also where you've got the health plans integrating and continuing to partner with different types of groups like the Florida Medical Association and discussing, how important credentialing is for those individuals coming into the market that are just graduating from college. Give you an example here in New Jersey at the Mid-Atlantic, those individuals from Princeton, for instance, that are graduating, before they graduate and become an actual true life physician in the marketplace and sign a contract with the health plan and payers and starting to see individuals, is the colleges, the universities, the medical schools provide a level of information that is true and tried. They credential their students before they graduate. And they credential them to the point where they reach out to health plans. Princeton University is one that will reach out to health plans and get those students connected, those physicians, those practitioners connected in with the health plans and payers, get that contract negotiation started, and again, complete the whole process so that the student, the medical professional, is focused on coming out of school and starting their practice or working with a group of physicians, or if they decide to work and contract with a particular hospital. So again, that's important to understand when we talk about interesting facts. Also understanding that our country is continuing to look and see how effective our credentialing process is. Currently today, I'll use the South Atlantic as another type of example. In the South Atlantic, and all the states that you see here in the South Atlantic will have a different type of credentialing application. The healthcare industry has reached out and said, can we combine applications? Can we combine the process for credentialing? So interesting facts is some states have come together to see what we can do collectively on credentialing. I'll give you an example. In the state of Texas, the state Medicaid program has come to the conclusion that from their alliance in that state, they have taken the health plans and brought the health plans together who are part of the alliance and formulated a transparent, uniform credentialing application for their practitioners as well as on the facility side. So there are definite opportunities and things are happening all over the country, but the really focus is around making sure that we are able to credential in a time frame that brings the practitioners into a health plan and payer network. So again, all this information and interesting facts are very important to understand that as we continue to grow as an industry, we're going to see more and more opportunities to improve on the process, to credential in a uniformity way, a pattern, utilizing information very quickly and getting practitioners in networks, but also making sure that people feel comfortable, consumers of healthcare in general, feel comfortable with their health plan's provider network and feel comfortable knowing that these individuals have been credentialed and certified and truly vetted in a way that brings more participation and more membership. State Medicaid, Medicare Advantage, traditional Medicare, commercial line of business. So again, it's not just one particular health plan and payer, it's across our country. And it's community-based health plans as well. I do want to bring that to our interesting facts and getting close to the conclusion of this particular initial session. But there are community-based health plans that focus on rendering services to a particular population of individuals in a particular community, unlike the national health plans and payers like United, Aetna, Cigna, Anthem. There are community-based health plans that really try and drive the level of quality of services and bring in the highest level physicians that practice a particular specialty. And again, this is going to continue to happen as we see community-based health plans become more of an active player in credentialing. They're able to effectively pull providers into their network more effectively and efficiently because they are more electronic enabled. They're more engaged, especially in the urban areas where there's more focus on bringing the paper credentialing application process into an electronic, maybe a scanned, fax, OCR, portal, electronic data interchange, or even another type of language. And we're going to hear a couple of other sessions. We talk about FAST, which is a whole different language of bringing credentialed providers into network. So focusing on technology and alleviating, I should say, paper in the credentialing process is key. And as we continue to become more technology friendly in the industry, you're going to see more and more standardization. You're going to see more applications available through an online application, a portal, a health plans vendor, clearinghouse that provides a particular method of communicating all of the provider credential data and a stream of communication to a particular CVO. So again, understanding that we are continuing to evolve our credentialing process since 2014, it's important to understand that these are facts for us to understand as we continue to participate in healthcare. And it's important to surface up concerns and issues and opportunities. So again, bringing this information forward will help us all work better together, collaborate, and alleviate any discrepancies or inefficiencies and improve in our healthcare processes. So again, healthcare is very important to all of us. Of course, most of us are consumers of healthcare. So one last thing that I think is important for us to understand is more around the information that we just got through looking at and how the United States and the U.S. territories are divided up, but also better understanding the population of those individuals throughout the United States and the U.S. territories. Individual physicians with active license, and again, this is based on the U.S. Census Bureau from 2014, and it continues to grow year over year as we get individuals from internships and colleges, universities, into the actual practicing of medicine and rendering services or medical care and services. You're going to see this continuously evolving and growing and shifting and changing, especially when we divide the United States up. The South Atlantic I kept utilizing as an example. Well, as we go here and look at this particular chart, out of those individuals coming out of college and universities with an active license, are those individuals, 19% of those individuals are really coming out of the South Atlantic. 19%. That's pretty high considering the fact that, we've divided the United States up in the U.S. territories. Something else I think is important when you look at this chart, again, it continues to change as we do fact-finding and we get information and we study those individuals coming out of college and understanding those individuals and how they're credentialing and who they're reaching out to credential. That's also the other important item here. But the total in the U.S. and in D.C. as well is licensed physicians, 1.2 million. So think about the opportunity. We're continuing to grow, so that 1.2 million is continuing to climb. It's not climbing very fast, but it's climbing year over year. Some of the population counts, which I think is very interesting, some of those physicians and practitioners continue to look at areas of different locations because, again, depending on the level of practitioner that they've become certified and licensed for, they may go and relocate in a different location in the United States. So also another fun fact, physicians on an average, and I'm saying physicians per 100,000 population of individuals, it's around 385. So again, understanding respectfully that's changing as well because, again, as we continue to grow the population of physicians, we're also, growing the population of mid-level practitioners. And again, this is really focused on the physician aspect of it. If we were to take the facility side and pull that out, you would see a lot of information that changes even monthly throughout the United States on the facility side. Because again, facilities are bought, the change of ownership that I discussed earlier, we call it the chow in the industry. Those are exchanged when facilities merge, buy each other up, or combine services. So that would be an interesting number. And unfortunately, today we don't have access to that particular information. But we're getting to a point where that information is being shared. So hopefully, our next session on credentialing will really be focused on the physician side. The third session will focus on the facility side. The fourth session will focus on the atypical providers. And then we'll get into better understanding how health plans and payers really integrate with each one of those particular level of individuals. So with that, I am going to leave you with this information, and we are going to publish this information out on our WEDI.org site. But if you have an interest in really participating with us, we would really like to have you join our provider information subwork group at WEDI.org. Please feel free to go out there and register. And again, we would like for you to participate with us. Any questions you have, bring them and yourself to our provider information subwork group, and we meet once a month on Wednesdays, and our calendar is available. So again, we would love to have you. We appreciate your participation. And again, if you have any questions and you would like to join our team, please feel free to do so. Thank you.